All right. Well, we've got a few housekeeping items, so I'm going to actually jump in and go through those while we're waiting for additional folks to join us here today. First of all, a wonderful afternoon or good morning if you're on the West Coast. I'm Jen Kovich-Bordnick. I am the CEO of the eHealth Initiative and Foundation, and so delighted that you can join us here today for this incredible session we've got going this afternoon. We actually have two action-filled panels of experts talking about really this new era of healthcare. And I think we've got a lot to jump into this afternoon. I do want to run through a couple of quick housekeeping items. These should be old hat to everybody by now because we've all been on Zoom for over a year, but everybody's muted. We do want your questions. We got a lot of questions in advance through the registration process, but we're going to try to get to as many as possible. So please go ahead and start sending your questions in through the Q&A box. All your questions about SDOH, patient engagement, how to make this thing work. We want to hear from you, and feel free to direct your questions to specific speakers or just as a whole to the whole group. And we do want to know if you see somebody else that's already put a question in there that you really want to know the answer to as well, you can go ahead and just put a thumbs up sign next to it, and that'll let us know that we really need to ask that question. So go ahead and do that. If you've got technical difficulties, jump into the chat box, and Sarah, Brian from our staff is happy to help work through those with you. Let's jump to the next slide. So as I mentioned, we've got an incredible group this afternoon. We're going to actually start off talking about the data itself and how to maximize data analytics and technology, and really kind of zero in on whether or not you have the right data that you need and how you're targeting consumers. Really figuring out how different companies are doing that quite well. And we'll hear from groups like Walgreens and Amwell, Maine Community Health Options. And we've got two great experts from Inovalon and Amwell to join us today as well. So who are just all over the data. So I think we've got a great crew with us here today. Then we're going to at 1 o'clock jump into a little bit more. Now that you actually have the data, what do you do with it? And the data on the specific patients. We're going to hear from Amy McDonough, who's with Fitbit Health Solutions, now part of Google, a managing director and general manager, doing all kinds of neat stuff and research around that really Fitbit data that I think we're also familiar with right now. And then we'll do a lot of questions as closing thoughts here. It's really all of your questions we're going to be answering there at the end of the panel. So we encourage you to stand by and stay on for both panels. We've got great information to share with you today. Next slide. If you're not familiar with eHealth Initiative, we are a group of executives from across the spectrum of healthcare, and we're really trying to figure out how do you use innovation to transform care. And we've got an incredible group of leaders from across payer, provider, vendor groups, researchers, academia that work together on some of the toughest issues in healthcare right now. Next slide. We do education, advocacy, and thought leadership around a couple of core issues. If you jump to the next slide. The issues that we work on right now are consumer privacy for health data, doing a lot of work around virtual care, which we'll talk about today, analytics, social determinants of health, and AI, which again is what the topic today really centers around. And I think everybody's world has been revolving around COVID-19, best practices, and how to really use the data that we have right now to address the pandemic. And it's certainly been an educational year for all of us. We've done a ton of forums and webinars that we would love to share with you. We are a nonprofit, and our mission is really to help transform care. So we want to share this with you. These are all available online, and I encourage you to forward these, go through them, pull down the slides, read the reports in these key focus areas: privacy, telehealth and policy, COVID-19. You can see there's a whole slew. These are some of the most popular forums that we've done over the last 6 months. And we've released a number of publications as well over the last 12 months, several having to do with COVID, telehealth, reimbursement policy, guiding principles for the use of social determinants of health, and a couple of reports on how to use SDOH data right now to target specific consumers. Next slide. Couple of important dates coming up. We have another really fantastic webinar later this week on interoperability and physician burnout. Encourage you to join us tomorrow for that. We're going to be doing FAQs on digital health credentials. We don't say the V word, or the P word, passport or vaccine passport. Some of those issues are likely to come up on June 1st when we talk about those issues. We're also going to be having a member policy briefing, a lot going on right now in the regulatory world. We encourage you to join us on June 21st for that. And we'll be talking about patient matching and identity access management on June 30th. All of these are available to you free of charge, and we encourage you to register for these programs. And a big thank you to Inovalon for supporting and underwriting this program. We are a very small nonprofit and would not be able to provide the programming that we do and the education that we do without the generous support of groups like Inovalon, we're really fortunate to have Eric Sullivan on here today, who's also a member of our board of directors, and a really staunch supporter and friend of EHI for a number of years. And we're really lucky to have him. So I do want to thank him for his support. Go to the next slide. So we're going to go ahead and kick off the first panel here today. We have Will Kilbreth, who's the Senior VP and CIO of Maine Community Health Options. We have Eric Sullivan, who I just mentioned, the Senior VP of Inovalon. We've got Hope Grau, who's the Vice President of Amwell, and we have Stacy Ward Charlery, who is also a PharmD with the AllianceRx Walgreens Prime. Stacy, I hope I said that all right. Long title.
You did really well.
Okay, AllianceRx Walgreens Prime.
Right.
So great. So another, I think, reflection on how this industry has really changed as we're starting to look at how all these different pieces of data kind of pull together. So let's jump right in if we could. And I want to also, again, encourage folks to start putting your questions in. We're really happy to hear your questions. You can put those in through the Q&A box. And I'd like to just kind of jump in and first of all, just ask our panelists here to just really briefly tell us in a minute or so, kind of what is your general consumer-centric approach for your company itself, just to give folks a sense of what your company does and how you approach consumers. So why don't we just do that so everybody can come familiar with what you actually are doing. And we'll start with Stacy, since you're in my upper corner here.
Okay, number one, first I just want to say thank you for inviting me. It's a really honor to be here today. I would say in kind of a nutshell, the way we look at consumerism at AllianceRx from a pharmacy's perspective is that our patients are consumers, right? And so we have a unique opportunity here to really transform the way we think about patients as consumers and kind of putting them into the driver's seat of their own healthcare. And so we are in the process or kind of in this evolution or transformation of making that switch. And things that we do in that to help us with that is, again, trying to understand their data, trying to understand their whole person, trying to understand how this particular this prescription fits into their entire, the lens of healthcare. And so it's a little bit of a shift kind of moving from patient to consumer, but it is definitely, I think, where the industry is going and will help us get better at taking care of that entire whole person.
Great. Hope, why don't you share with us, what about Amwell?
Sure. There are a number of folks on the phone or on the call today who likely know what we do, but for those who don't, Amwell is a telemedicine company. We're actually a technology company that enables and brings folks together to make care more accessible and affordable. Therefore, really working towards our mission to democratize healthcare and beam it in, if you will, to folks who may have access issues to healthcare. We actually power connections between all parties within the healthcare ecosystem, whether they be patients or providers, innovators, and insurers. Today, we're going to be sharing some of the successes we had in reaching some vulnerable populations, especially during the pandemic. There's some really amazing ways that we can harness data. So I'm so excited to be on this panel with my colleagues to talk about the data that's available. What we work very hard to do is to identify folks through data that we can do outreach to make them aware that they can actually get care, whether it's urgent care, behavioral health, or access their own community resources or physicians through a video visit or through other technology that we enable here at Amwell. So really excited to share what we're doing and to just engage in this conversation.
Great, welcome, Hope. And Will, tell us about Maine.
So, hi everybody, good afternoon, and Jen, thank you for having me. So just for background, the organization that I'm the CIO of, Maine Community Health Options, is one of the last 3 remaining co-ops formed under the Affordable Care Act. So by definition, we are member governed. Majority of our board actually has to be members. So, I think to a great extent, being member-centric is kind of written in our DNA. That being said, I think, and this is just sort of a preview of probably other comments I'll make throughout the rest of the hour, I think what we really learned is that there's no one size fits all, and that you have very, very different member needs and member engagement patterns. Our marketing director talks very much about user journeys. And I think, for all of us who work in this industry, we know, just based on the actuarial tables, you have a very, very highly engaged population that's narrow, and then a larger population that's less engaged with you. And coming up with digital solutions and data analysis that serves both of those populations, I think, is really the challenge for us, is how do we provide tools that meet all of those segmented populations? And I think so that's what I spend a lot of time thinking about. And hopefully we'll get to talk about that a little bit more.
Great. And Eric, why don't you tell us a little bit about Inovalon for folks who are not familiar with Inovalon? You guys have a lot of access to consumer data and work in this area a lot.
Yeah, sure. Thanks. Yeah, Jen, thanks for EHI for having this event as well. To echo my colleagues here. So, Inovalon supports a large part of the specialty pharmacy and the provider community on the payer side, which is really where I come from at Inovalon. We're working with 140 health plans, including Will and his team at Maine, to try to advance quality of care, try to advance, risk score accuracy, leveraging a lot of tools like interop and telehealth and other technologies. But our mission to improve quality and risk for our, in this case, our payer clients, as well as our provider and specialty pharmacy clients, really comes down to us, Jen, leveraging the data we have, right? Maximizing the ability for us to correctly profile patients. Not hitting this more later this morning, but our mission is really going to be data centric to get the right data identified or analyzed, the right patients identified, and ultimately how do we engage them correctly? Because when I started in healthcare 33 years ago or 34 years ago now, the same challenges we had then, that for every 100 people you want to engage, you may get 10%, sometimes even less in some cases, engage. That problem persists. So to Will's point, let's talk about the technologies and how do we get better. And that's kind of why we're here today.
Great. And last but not least, we have Fred Bentley with Avalere Health. Fred, maybe you can explain to folks how Avalere works with its clients to help with some of the
Sure. Yeah, and again, also thank you to everybody for joining this session and for letting me participate. For those of you who will be in both sessions, you'll be hearing a lot from me. So, just to clarify very quickly, so Avalere is a Washington, D.C. based research and consulting firm. We're actually a wholly owned subsidiary of Inovalon, and kind of the easy way to think about it is we're the consulting arm of the Inovalon family of companies. And so in terms of how we think about members and how they fit into the work that we do, we're not interfacing directly with the consumer, but we support everybody who does, right? Payers, providers, kind of the whole gamut of companies that are interfacing directly with patients, with health plan members. And so we do two things that really are where we're very member focused. One is, especially, we're a DC based firm. We do a lot of work in the policy space, and given just the array of rules and regs that have come out recently, we've been incredibly busy working with payers, providers, again, kind of the whole continuum, helping them understand, what do you have to do? You know, what are you expected to do now, and when do you have to do it? That, you know, it's interesting stuff for us. I'm a policy wonk, but I'd say the more exciting work is, okay, if that's what you have to do, what should you be doing? And that's where I get to work with Eric and his team, helping our clients really understand, how do you integrate all this data? And ultimately, how do you get as comprehensive a view of your members or patients as possible, so that you can be much more thoughtful and targeted and data-driven in your outreach efforts? And way easier said than done, keeps us busy, but that's really how we're helping our clients engage with their members.
Great. Well, I'd love to hear a little bit from Will and Stacy, you know, specifically what kinds of data you're using to actually target some of your members and consumers for specific programs. Maybe some examples you could give us from the recent pandemic, or any programs that you're specifically running. Kind of tell us what it's like in the real world there. Will, why don't we start with you?
Sure. Well, you know, as I think will always be the case, we never have as much as we want. But, you know, we are, so we have the full array of what we consider administrative data that we obviously use, and claims being the primary source of that, and, you know, both on the medical side and the pharmacy side. And then we plumb, you know, our authorization system as sort of our early alert system. One thing that we are working on right now is there's a HIN in the state health info net that has access to all of the clinical information. This has been a long-standing battle in terms of figuring out, brokering some sort of agreement where we could get clinical information out of the clinical data share. And we finally are starting to get somewhere with that. It's actually not direct clinical data, but it is risk scores that they produce based on their entire database of clinical data. And we're looking to pilot getting ADT information out of that system, which I think is going to be really useful. You know, one thing I'll mention is that, you know, that's part of this partnership that we have with Eric and Inovalon, is sort of thinking about how to build out our clinical warehouse. So we're targeting interoperability with them initially, but because that's all based on the HL7 FHIR standards, it's really giving us an architecture to start capturing clinical data signals coming in from our provider partners as well. And then we do a lot of work with various initiatives that require chart chasing. So we have RA work that we have to do. We have the whole, you know, edge server process. We have the HEDIS work that we have to do. And so we do have those charts that we can again sort of plumb for information. But I, you know, just as sort of a, you know, commenting on that a little bit, I mean, it's hard for me to overstate how much elbow grease goes into that versus sort of heuristics or AI. I mean, we have a very dedicated team of clinical staff that basically comb through that stuff and then dig into the record and make recommendations in terms of how we engage with that membership. We have not necessarily figured out that sort of secret formula that collates all that data and says, okay, this is somebody you've actually got to go engage with.
So it's not a magic algorithm yet. It's still a lot of manual work. Yeah,
and you know, those people we've worked with around those sort of secret sauce magic formulas, there's always sort of an 85% Venn diagram. It kind of works, it kind of doesn't work. So
yeah.
So I guess I'll stop there and let Stacy chime in.
Stacy, jump in. How about you?
Yeah, so I think I echo some of Will's comments. You know, we have, as a specialty pharmacy, we have prescription data, right? That's kind of our wheelhouse, our bread and butter. But we have started to, again, kind of look at what other clinical data can we supplement with our prescription data. Again, trying to, you know, specialty pharmacies are kind of in a unique position where, you know, we dispense medications and we have to dispense medications accurately and help patients get to the medications on time. But we also are a partner for our payer clients, right, and other stakeholders. And how can we do more? And so in order to do that, data is really data becomes this powerful like unlocking mechanism. And so we understand that, you know, getting additional clinical data is beneficial, and that we rely on, and we're partnering with Inovalon through some of their data stream products to pull in different information like diagnosis codes, and can we look at medications? Can we even get to a point one day when we can look at lab values and kind of build that clinical profile? We also look at data in terms of what we have, and we were able to construct a really good patient profile based on our connected care programs. And so at AllianceRx, we've got these connected care programs that are disease state specific, where our clinicians are asking questions to the patient, right? So one of our really strong assets in the pharmacy is that we have frequent engagements with the patients. Like we talk to them every month to get their medication scheduled and get them shipped. And so in our connected care programs, we're able to collect data or, you know, see if the medication is working for them, see what barriers or challenges they have. So we've got a data set from there. The part that we're really trying to explore more now and get into is looking at these social determinants of health data sets. And there's a lot out there, which is great. There's the free data sets from CDC. There are companies, you know, some of the large credit bureau data companies, TransUnion, Experian, LexisNexis, there's a lot out there. And so the good news is that's great. I'll echo what Will said is there's a lot of elbow grease that goes into to getting access to the data and actually making that meaningful and trying to get to I think what we all want is the risk. How can we take that data, identify those patients that we want to target? And that's a lot harder than I think most of us probably here know that, but a lot goes into that. So it's great that we are making advancements in getting the data sets. I think the work now becomes in how do we take the data and make it meaningful and be able to risk stratify these patients.
So Eric and Fred, so we've heard there's a lot of elbow grease that goes into this. You guys work with dozens and dozens of companies that are using this data. And can you share some examples where they're actually using some of these more advanced predictive analytic approaches to identify specific target populations?
Yeah, I can start, and Fred certainly, you know, chime in. And I just want to echo Stacy's point. I mean, it is, you know, and well, I guess we're a lot of echoing here because we're all in the same boat. You know, now we get all this access to more data like the social determinists, as Stacy mentioned, but, you know, then it comes down to how to use that, right, to actually make a difference, do something different, how to use it to tailor your engagement. And that's been our focus over the last, call it 18 months, you know, is really trying to, now that we're building, you know, as a probably overused term, that, you know, patient 360, but, you know, now you have claims clinical as well as mentioned with the EHRs and social determinants and other information. What models, right, do you do, and how does that make a difference? So we've been putting a lot of time into our machine learning and deep learning models. Well, I'll give you one tangible example. There's probably plenty. You know, is fall risk. Fall risk is a really big concern for Medicare Advantage plans. I mean, it's an outcomes and a disaster for people who's like my mom who fell, and it's just. And there's a lot that can be done there. It's a very often avoidable, but it's a very costly and very sad event for seniors. And we've taken a lot of the claims and clinical plus social determinants to understand, you know, how do we engage Medicare Advantage members in this case on the consumers on their risk. And a lot of times you'll find that the risk is heavier for not just on medications they're on, whether it's you know, or drugs or underlying conditions, but often, you know, it's on their, you know, their income level, their education level, they live alone, right? That's a big driver. And so how do you, with that information, how do you use that then to engage, as we do with our, you know, our kind of in-home nursing team, which was very hard during the pandemic, frankly. I mean, we were all challenged with engaging consumers, and that's why we were working with, you know, in telehealth and folks like Amwell to advance that. But, you know, it's, leveraging that data, running AI and machine learning models, Jen, can help to start making it more patient-centric, because then you can say, well, it's not a vanilla approach like old school disease management. This is really about what is specific to Eric that we should do, and how does that help us kind of titrate our engagement? You know, maybe we all know millennials, you know, I think the stat is what 75% of millennials prefer texting. I guess all of us older folks prefer other things. I don't know, but it's true. I mean, and so how do you use this to do a patient-centric engagement? And ultimately, then a year from now, Jen, we'll ask, did it make a difference? And I think that's we're still in the early innings of this. I don't know, Fred, if you want to add on.
Yeah, you know, some of the interesting work we've done really runs the gamut from what you would think is very basic blocking and tackling, and you think it's basic until you actually get in there and working with, in particular with health plans around basic stuff around, all right, you have engaged with a new member, you've got some survey information, some assessment information about how they like to engage with you and their preferences around communication. You know, it's very rare that the plans we work with, and I'd say this is true of providers, maybe even more so, that everybody who touches the member or the patient knows that communication preference, right? Is this somebody who really enjoys getting outreach? Or is this somebody who's basically like, hey, I'll get in touch with you when I want to get in touch with you, and until then, leave me alone. And so, you know, it's really unsexy. It doesn't sound very cool, but it's just the basic stuff you can do to engage and meet consumers where they are and where they want to be, you know, how they want to be engaged. I think, you know, so we're working with clients at that end of the spectrum, all the way up to some really interesting work looking at with one plan who now is accessing clinical data on a routine basis, combing through the physician notes using natural language processing, NLP, to identify the markers and the hallmarks of patients who are suffering from social isolation and loneliness. And that is, you know, it's really cool. And here again, we're in the early innings. And like Will, I wish I could say I had like, you know, we had the examples and here's what you do, but just being able to identify those members and start to think about, okay, how could we engage them? How do we start to address this? That's really exciting stuff. And that's when it's really gratifying to know, like, we've got all this data, we've built all these capabilities. This is how it's actually going to help members in a very meaningful, tangible way.
Yeah.
So Hope, you're engaging with millions of new consumers who are accessing virtual care now, and I know you do it both synchronously and asynchronously. Can you talk a little bit about kind of what you have learned about consumers over the last year? I mean, you have a fairly, I would say, new, huge population to work with.
Yeah, well, and it's interesting because, you know, the pandemic certainly amplified enormously the power of telehealth and the need for it, especially when people were afraid to go to their physicians or were otherwise hard to reach because of other social issues. Isolation and others that Fred mentioned are a big part of that. And it's interesting for us to be talking about all of the different uses for really granular data in outreaching for care through like the work that Stacy's doing and the work that Eric and Fred's clients are doing, what Will's doing. You know, one of the things that all of us talked about, the panelists talked about when we were speaking earlier, was how important it is for those outreach opportunities to be really relevant to who we're reaching out to, and therefore why it's so important for us to have great, you know, great insights on a consumer to make sure that we're only pinging them when they want to hear from us in a way that's important to them, to make them aware of the different services, or whether it's clinical services or our telehealth services that they can leverage. So from our perspective, we're really helping health systems or health plans reach out to their members to make sure they know that telehealth is an option for them. And what we've learned is that, you know, by leveraging a number of different mediums, multi-channel, we really greatly increase the chance of reaching people, and we see the results of those outreaches through registrations on the platform. You know, I think it's no secret that telehealth use just exploded during COVID, and what we could actually measure when we deployed a certain outreach marketing campaign to let folks know that they had this service available to them, and then significant spikes in registration and then visits on the platform. And you know, everything from—
go into a little detail about that, because I know people are very aware of the virtual visits, but when you talk about other channels, what do you mean?
Well, what I mean by, I'm speaking of outreach and marketing channels. So things like text messaging and email campaigns, and believe it or not, even good old fashioned mail. We do a lot of campaigns through the mail that, you know, intuitively we may think wouldn't be effective, and yet we can see significant spikes in registration and then visits thereafter. I'll give you one example that we really saw come to life in the midst of COVID. Metro Plus is a health plan in New York City. They have about 550,000 members, you know, 72% of which are Medicaid. So typically hard to reach members. And we did outreach for them through you know, some of those means, whether it was text or mail or what have you, and they launched in the midst of COVID. I believe it was in March, and they had 7,000 people register for Amwell shortly after our campaign. You know, over half of those 7,000 actually had a visit, and a large percentage of that population was the managed Medicaid population.
Wow.
And so, yeah, it was great to see. It was a population that really needed help and care. And in addition to sort of meeting people perhaps at their homes, we've seen really great other uses of telehealth by taking devices to where people are. So whether it's homeless shelters or retail settings or other pharmacies where people who may not have access to digital assets can actually go and seek care. So we're trying as many ways as possible to make the investment that health plans or health systems have made in offering Amwell and a telehealth platform to make sure that they can capture people and actually and bring access to affordable care for these folks.
Jen, if I can add one point to what Hope's saying, one of the things that we ran into last June, I guess, June or July, was obviously the explosion of telehealth, which was fantastic. We were trying to engage, folks where they were, and for all obvious reasons. But so many folks, and Will and I discussed this when we were just talking about engaging folks in Maine. Not everybody has smart devices. Not everyone has smartphones. I just assume, I can just assume everybody does. And the reality is large pockets of the U.S. that still do not, or don't live within a 4G, 5G environment. So
broadband, right?
Yeah, right, exactly, right. I mean, I think EHI just did a session on broadband last week, but I think that we ended up deploying a device-on-demand solution just to bring devices to people, because it sounded great to them on the phone, but then they had no way of engaging without they didn't have laptops with high CPU, and they didn't have smart devices. So it really is meeting the consumers where they are, and sometimes helping them with just flat out giving them access to devices to make the communication possible. I don't know if Will, you ran into that as well, but.
Yeah, no, I was going to tie together the comments that Fred and Hope made. I mean, so we talked about data access to social determinants of health, but exactly this concept of capturing people's communication preferences and understanding, as we've been rolling out Amwell, running into this broadband issue, like what do you do? You've got this perfect storm, as we've been talking about, of COVID, and this real need, I mean, in Maine, that has a really deficient behavioral health network of providing these services. And so telemedicine is a perfect solution, but you have an older population that's very rural, that doesn't necessarily have, as you say, Eric, I think for a lot of us, it's like, we'll do a Zoom call, or we'll do it on our phone or whatever. But if you're not sensitive to how you can communicate to these people, then they can't take advantage of the service. And so how do you get over that threshold? And that tracking, what sort of preferences the consumer has and what sort of access they have becomes a really important part of the delivery solution.
Yeah, if I can jump in there, I think it's all really good points. And kind of my opening comments here, I think for a long time in healthcare, we thought of patients as patients. But when you start thinking about patients as consumers, really understanding their preference is important. So if you think about pharmacy years ago, we provided hard patient education. Every time you fill a prescription, in your prescription bag, you got a paper of, this is what the medication is used for. And I would probably have to say that some people read it, but probably a lot of people didn't read, right? And so now that we've advanced in digital capabilities, we've advanced in SEOH, we've advanced in so much areas where we've got more data, we've got to now marry that up with preference. Like, how do you want to be communicated, right? Do you want to have a conversation with your pharmacist and have it be one-on-one counseling? Do you want to go back and maybe we text you a link to some information that you can read on your phone? Or do you want the print materials? You know, we can't necessarily move away from everything that we've done in the past because it has worked. Now we have to say, what else can we add, and how do we get people into the right channel, right? So it'll be effective for them. So again, getting more into that consumerism, more personalized care, as I think where we are heading, which is really positive.
And I just to add on there, because you know, data nerds like myself and maybe some of the other folks on, I won't impugn other folks on the panel, but we get super excited, and for good reason, around the, you know, bringing the clinical and the claims data and now the social determinants data, and that's all great, but you know, there is a real risk here of you know, going to a senior and saying, we understand you have challenges with transportation, like, where'd you learn that? Why are you coming? You know, so you really have to be thoughtful and careful about it. And again, you know, I not to sound like a broken record, but it is just understanding what is it, how does the patient want to be engaged with? Would they be open to that, or do they want to be left alone? Because it can really be counterproductive if you're not, you know. So on the one hand, it's great to have all the data, and there's all sorts of cool stuff and important stuff that you can do with it, but then it's, you know, you don't want to just open the floodgates and right, it starts to feel kind of like this Big Brother kind of approach, which is not effective.
And I think, you know, Fred, this may be less of a problem for Stacy, but for those of us who represent health plans, you know, a lot of the time the member doesn't want to hear from us, right? I mean, we're a barrier. Right. And so if we show, you know, I'll just tell you a little anecdote. I mean, we had nurses calling new moms, you know, after they gave birth, just to check in, see how they were doing. And we had so many people tell us, oh my God, I thought you were calling to tell me that you weren't going to pay for this. Right. I mean, that's what they thought we were doing. And so that's the reaction. So how, as a health insurance company, do you insert yourself in that delivery model in a way that's actually going to help the member and convince them that you're going to help them? And one of the things, you know, we think about a lot is, well, do we just drive this through partnerships with our providers? You know, we don't need to be the client facing or member facing piece here, but, you know, can we drive this through value-based contracts or ACO relationships? And, you know, we're still working on that, but it's, but I do think, to your point about the sort of Big Brother aspect, I mean, we're dealing with not only that, but the fact that most people have a kind of negative impression of their healthcare company anyway. So, you know, that's an interesting balance.
Will, why don't you expand on that a little bit? Because I think that's a great point, because you do kind of get a bad rap as a health plan. So talk a little bit about the partnerships that you're using, other than the providers. Certainly the provider is the first that comes to mind, but the types of partnerships you can have to do that consumer engagement.
Well, I think, you know, we've done a lot with sort of councils on aging, with home health agencies. Again, I mean, this is all sort of falling under the broader provider umbrella, but as you think about sort of organizations that provide greater services, you know, around these social determinants, transportation, you know, to get to your provider, you know, things like that. I think our clinical team does a lot of work with those types of organizations. I mean, one of the super advantages of working in a small state like Maine is that, you know, we kind of know, we all know each other, and so those connections and relationships can really be leveraged. But I think, you know, from a digital solutions and consumer engagement perspective, you know, we're still trying to figure it out. I mean, you know, we're not really talking yet about interoperability and the transparency tools and all the things that consumers are telling us that they want, right? Tell us how much this is going to cost. And I think that's the area where, you know, we're going to be able to provide value, immediate value and tangible value, in a way that doesn't seem like we're interfering with their care, but we're actually helping them. So I think, that's I guess where I would go, Jen, is, what tools can we provide the consumer that's going to help them feel empowered as opposed to feeling like they're being directed. So, that's the challenge.
Stacey, how about you?
Yeah, no, I would say, well, we should talk, right? I would say that, the pharmacies, I think, have a really, and specialty pharmacy maybe more so, but pharmacies in general have a really unique opportunity to be part of the solution. It's a really huge problem, right? And I think that it's hard to say that it's a health plan's problem to solve, and it's hard to say it's the provider that needs to spend an hour with the patient to solve the problem, right? So how can we work together and kind of form this partnership to say, okay, maybe the pharmacy can help with identifying the patients and using our engagements to validate the information, because that's another piece too, right? It's the data is the data, but there's data latency, and some of these SDOH factors are acute in nature. Maybe you lost your job 6 months ago and you were in a financial hardship. That's not where you are today. So we can't necessarily assume we've got to put you in this bucket, right? So, how can you figure out as the stakeholder in this what your strong suits are and what your competitive advantages? Like, what do you bring and how can you help solve the problem? And we look at trying to find ways to partner with each other. We recently launched a pilot with Highmark, the health plan, the payer, where they were looking at this from a perspective of, we want to engage the patient. We've got programs. We're kind of investing in trying to really look at SDOH, but they were not having as much success in engaging the patients. And so they said, okay, from a pharmacy perspective, is there a way you can help with that? And so it's a very small pilot, but we've seen so much good outcomes and positive outcomes to date, where we're able to be have better success rates or better engagement rates than the care management team at the plan level. And we're seeing patients kind of trust us, again, kind of being in the forefront of pharmacy, and we've got nurses actually doing this work, but the trust is there. And so they're willing to share some more sensitive information than you would think that they would not want to share. So I think we're seeing success there, but to the point, I think we all have got to figure out how we can help and then form those partnerships, right? And maybe it's a SDOH solution, or it's a broader solution with different people kind of working together. So I think that's one of the key things I think I would stress to folks on the panel here and then in the audience. Find a way to work together and reach out, because it's a huge problem and we can't really get there on our own.
Yeah, you said the word trust, Stacey, and that's something I was gonna piggyback on to Will's comments. And to the question that you asked, Jen. I think health plans have for a long time had a trust problem with their members. The fact that the example you gave, Will, was someone who was anticipating that the outreach was more about a non-covered claim versus someone who was just checking in with all the right intentions. And that lack of trust, I think, has plagued plans for a long time. Perhaps. Unfortunately, despite a lot of efforts to turn that around, one of the things that we've found, and we talked a little bit about making sure we target the right messaging for the right person to make sure it's relevant. And I think that is just one piece, making sure we're not doing a broad brush set of outreaches to a population that, maybe getting a diabetes communication when there's nothing to indicate they have a diabetes challenge or issue. And that's something we've learned at Amwell is, we really do try very hard not to just send broad brush messages, but something else, to amplify what you were saying, Stacey, about us all being in this together. We see a lot of strength and power in enabling trusted community resources to make those available, and in our case through our technology, but local providers that we become, we arm local providers with technology to continue to see their patients versus replacing them. And how can we all come together and talk about that touch point each of us owns or has a part in to make that end-to-end experience better for a patient? So I guess what I'm here to say is I think we could all probably talk about the role we could play in each other's challenges to enable that trust to increase and reach the right people for the care they need.
Yeah, I love that example you shared about, learning to not do kind of these broad brush targeting campaigns. I'd love to hear from the others. What are some of the biggest mistakes you think companies are making when they target consumers, or maybe misconceptions that we have about consumers and how they might react? Anybody want to jump in?
I can, I'll take that to start with. I think that, one of the things that we've done a lot of research in the last couple of years, and even when I was, 15 years ago, United Healthcare, we had the same issue, which was kind of what Hope hit on, this kind of vanilla approach. You can't engage everybody the same way. And yet, you find that that's still the case. You have a script on how you engage consumers. And in reality is, depending on a lot of factors, that script should be different. How you message. It's not just who are we going to engage and, what is their preference, but then when you're engaging them through that preference, what does the message actually say? And we found, when you start really analyzing like call center logs and things like that you get a very visceral reaction, kind of as Will said. Not everyone likes their health plan. It's just, so the reactions you get, so the messaging has to be so careful, right? Really, what are you trying to accomplish? Say, hey, I'm calling you from the health plan is not going to necessarily be the best message unless you quickly explain that it's about something that matters to them, the consumer. So I think that our experience, and this has really been in the last couple of decades of in healthcare, is you just have to get the messaging just right and personalized, delivered in the right path, but be able to pivot quickly, because consumers want to know why they're being bothered. We all do. Right? We all get junk mail. We get some random calls, and you want to know, why are you taking my precious time? So if you don't have a good answer for that and can really explain why this matters, you're going to lose them. So it's probably an obvious point, but it's something that we just continue to see in our engagement with millions of people.
Yeah, another thing that we see quite a bit of in terms of kind of worst practices or challenges, and again, this is working with larger health plans and health systems, is not even getting your act together within your own organization. So I completely agree with Stacy and Hope, the points around collaborating across organizations, but we spend a lot of time just trying to get the internal groups aligned, and it's the standard kind of internal politics and siloed data, and why do I want to share that, and what are you trying to do to subvert my role or my importance? All of which you would expect. It's human behavior, but what it translates into is contacting the same member, the same patient 2 or 3 times, and not being consistent in the messaging, being like tone deaf. And I hate to say it, but it's absolutely true that in this instance, healthcare is just so far behind virtually every other consumer industry in terms of being smart and sophisticated and coordinated. So there's a lot of work just to get the organizations aligned and kind of singing from the same hymn book when engaging with their members or the patients.
It's interesting. What came to my mind when you were saying that was we all in healthcare talk so much about longitudinal care, and what we don't talk enough about, and this could be translate into a mistake I think organizations are making, is we don't think about a longitudinal experience, and we don't journey map out what a consumer's experience is in their interaction with either the healthcare delivery system or a health plan. And if we did that, we would actually be able to identify that we're pinging a consumer in these 5 different places, not realizing with the best of intentions that we're doing an outreach to help them, but rather we may be reaching out to them. We may be the 10th outreach they've had, and it's overwhelming and it seems disjointed, and it exposes what you were saying about, not having your act together. So I think I haven't seen enough healthcare organizations map out that journey for consumers. I've been with one company that was a healthcare technology company that did that on the client side, but not the member side. And I think it's something important maybe for us to start thinking about.
Yeah, I would agree with that on the patient journeys. I think that we're starting to head down that direction. We've done some really good work with different partners in doing the patient journey. What I think we need to challenge ourselves to is, as if you haven't done patient journeys, first do them. If you have done them, revise them and really look at it from the context of health equity and some of the context of SDOH, right? So is that journey the same for someone who's having financial hardships versus is that journey the same for someone who's having isolation issues? It's probably not the same. So I think step one is to do it so you understand where some of the overlap and redundancies are and kind of can smooth out the experience, but then go one step further and say, okay, let's look at this from these different SDOH point of views. And then do we now, and people may say that's too much, or you'll end up with 20 different journeys. And then how do you translate that back into workflow? How do you use it? We have to solve that too, but I do think it's a step in the right direction to start looking at these journeys from the different lens of SDOH.
Yeah, can you explain for folks what a patient journey is?
Yeah. So to at least at AllianceRx, what we think about a patient journey being is, again, a prescription. You may think it's a one-stop shop. Your prescriber, you left your office, you got a prescription, you come to the pharmacy and you fill it. But there's so much that goes into that, right? So usually, if you think about it from a specialty pharmacy standpoint, that patient is getting diagnosed sometimes for the first time with a pretty complex and disease and is going through a lot, right? And so what the patient is experiencing when they come to the pharmacy is a lot, and we have to take that into consideration, the mindset that they're in, to be able to, like, that's not the point where you want to jump in and talk about side effects, right? Versus all the way through, like they may be going through something, when you have to get a prior authorization and they have to go through different hoops to get the medication in their perspective, different hoops to get it paid for. And so they may be frustrated at that point. So your messaging may be different, or what you choose to engage with them during that phase may be different, versus all the way at the end, maybe they got their prescription, they're getting better, and you're in a different rhythm, or you got the medication, it didn't work, and now you're frustrated, or your disease is progressing. And again, what mindset are you in at that point? So I think of patient journeys as kind of what the patient is experiencing during the different phases of when you interact with them. That's my take on the patient journeys.
And Jen, I mean, one of the things to Stacey's point, I mean, just we ran some numbers recently because we spent a lot of time focusing on his handoffs. When you look at a Medicare Advantage patient or member, consumer, they're seeing on average 13 to 14 doctors per year, and that's not including the pharmacies and a lot of other ancillary at 10 physical locations. So that is, and that's just on average. So there's people on both sides of that bell curve, where there are people who are, folks that are seniors for sure, multiple chronic conditions, they're seeing 20, 30 different providers in a year. And just the confusion that creates for the consumer. So when we're reaching them out of nowhere to say, hey, check this, they're like, I've just seen 9 providers in the last 2 weeks. So I think without having that view, as Stacey and Hope mentioned, that understanding where they are, because it looks like a bunch of spaghetti if you really were to map out the journey for folks that have multiple chronic conditions. You've all seen those pictures. So, but yeah, 13 to 14 providers in 1 year for someone who's suffering with a lot of other issues and maybe, have issues with financial hardships, things like that, is really challenging. So this is such an important point.
And I would add, above and beyond the clinical engagement, can you see that they had a problem with their invoice last month? And how many times have they called the call center?
Right.
And, is this somebody who uses the website? Right. I mean, those are all things you want in front of your customer service rep or your clinical, staff. So, what I was going to say to you guys is that the thing about those journeys is you can kind of come at them from both directions. You can both be mapping them out in terms of, here are the profiles we think, map our membership, but then you can also be saying, I'm going to actually look at the data in terms of what our members are doing and all of those engagement patterns, and start building up those profiles from the data as well. And you don't have to start one way or the other. You can sort of meet in the middle.
So we've got some good questions. I want to try to run through some of these. For those of you who are hoping to improve engagement, what proof points are you looking for to convince yourselves that a new engagement strategy is worth investing in? So basically, how do you know something's working? One of the strategies. Hope, you want to take a stab at that? Oh, you're on mute though.
That's
There you
because
go.
that was my dog barking. I apologize, everybody.
Oh, we didn't hear it.
Oh, good. You know, I would say we look at metrics like, you know, do we see registrations onto the Amwell platform after communication strategy was deployed? Do we therefore also see increased visit volume? And, you know, and access, and for what types of care? We measure things like, if you hadn't come onto the platform for an urgent care or behavioral health visit, what would you have done otherwise? So demonstrating maybe where we've diverted care out of a higher cost setting into one that's appropriate through video. So those are some of the measures that we can tangibly look at to determine if something was successful.
Great. Others?
It's a tough thing to crack and not to crack, right? Because one, if you think about it, you know, to get your organization to invest in some of these new engagement strategies, there's money associated. So the question is going to be like, what's the ROI? Like, you know,
Yeah.
Please let me know what's the justification for investing in here. And so, you know, the measures and the success metrics become really, really important. And it's always like the cart before the horse, right? You can't really get those measures until you have some engagement. But one of the things we look at is just usage, utilization. For those who opted into digital, are they performing more digital assessments versus those who didn't? Are they kind of sticking through and doing the phone assessments, and is one area stronger than the other? Or we look at things, you know, from a higher level, just from adherence. You know, are patients more adherent, you know, with a different channel? And if it is, and that can help build the case that, you know, and I think we are starting to see some early signs of that. But if you are more adherent because you are engaged digitally and kind of doing these assessments and different things, if your adherence goes up, then that kind of proves the value. But it is hard, right? And proof points is always top of mind, and they're always the hardest thing to get. One, because you have to have the program or something developed, you have to have a way to measure it, and all those things, you know, kind of have to. It's kind of perfect world, you would have measures for everything, and you would be able to say this is why. But in reality, it sometimes you just kind of have to go with what you have.
Yeah, and I would say one of the, just as an example, Stacey's so right. I mean, it always has to tie to an ROI. We often will target a priority problem area for our clients. So for example, we launched some ER diversion campaigns, communication campaigns on behalf of some health plans who really wanted to sort of target high ER usage. And, you know, as a result of some of those campaigns, we've actually been able to demonstrate, you know, up to like $20 million in savings for those health plans across the board for care that was delivered virtually versus in an ER setting. So, you know, targeting some of those high priority areas, leveraging data to get to the message to the right people, folks who maybe are using ER for low acuity issues, and then being able to measure what the change of behavior was in order to drive that ROI. Really important metrics for us too.
So we've got actually another really interesting question. We talked about kind of building profiles of risk determinants. So this person is asking, do your practices actually codify these as temporary profiles because they could possibly be inaccurate appraisals, or are they kind of flexible in terms of how you, when you think about this consumer likes these things, or, you know, profile them in certain areas?
Yeah.
Fred?
Yeah, I'll take it. Sorry, chomping at the bit on this one because it's.
I can tell.
Yeah, it's such a great question, and I promise I didn't write it myself. Right. I mean, again, healthcare. You know, kind of the big picture. Healthcare is we're still in our infancy in terms of really doing this and doing it well, and there's a lot of catch up to be done. And as a result, you know, when we're working with clients, we're always careful to, you know, let them know that, you know, we're developing some initial profiles. Yes, we can port profiles from other clients and other organizations or types of clients, but you can't make it cookie cutter. And that absolutely, the profiles need to be adaptable. Also, just the getting on that refresh cycle. right? Because it can't be, well, they told me, you know, that they want to be left alone. So for the next 2 years or plus, you know, if we have them, if, you know, we're
Never
helping
hear from them. Yeah.
alone, it's like things change, you know, conditions change. They have new issues they're dealing with. And so there absolutely has to be a lot of flexibility there. And again, you know, just to kind of harken back to a point we were making earlier, a fair amount of humility around this, right? Of like, we may have the greatest statisticians and analysts and just super smart about this, and we've sliced and diced the right way. And, you know, that's great until you deal with one individual and you botch it, and hopefully not too bad. So it's, you know, kind of, yeah, introducing the messaging the right way and framing it the right way. And right, that kind of continuous feedback loop. And you know, to Will's point, I would just also say that, you know, it's amazing how folks in the call centers, the customer service, like, they are gathering such incredible intelligence, and it's real time, and it's very actionable. And again, in other industries, they have CRM software and capabilities that, you know, that can be added in and updated and refined, and we just don't seem to want to do that in healthcare. So yeah, there's a lot of learning to be done here, but right, you can't have these kind of fixed, rigid profiles for your members or your patients.
Well, I want to keep
If I can add in really quickly, Jen, sorry.
Hang on, let me just introduce Amy McDonough and Henry Archibong, who have just joined us. I know I introduced them earlier, Amy and Henry, but thanks for jumping into the conversation at this point. As a reminder, Amy is with Fitbit and Henry is with Inovalon, so Innovation Solutions. So thanks for joining us. And this is actually a perfect time for you both to jump in. We're answering some of these questions we got in, and this one question is really about kind of thinking about the consumer and how their profile or the behaviors might actually change over time, and how do you adjust for that? You know, you're trying to target populations to do specific things. So how do you account for the fact that they might change? They might decide they don't like to wear their Fitbit watch 24 hours a day, Amy, or maybe they're not exercising as much as they used to, or Henry, maybe they have decided they want to go to the doctor. They want to hear from the doctor more often, or they don't mind hearing from the health plan. So how do you kind of account for those changes in terms of targeting different populations? Amy, I'll let you jump in.
Sure, thanks, Jen, and really happy to be part of the conversation today. You know, I think as a primarily consumer brand who is now bringing consumer devices and partnering with the healthcare ecosystem, we think about engagement all day long. I mean, that's really at the crux of what we do. And so we look at metrics throughout what is a typical funnel, from participation to then ongoing engagement, whether that be with a device or an experience, and how they connect with that. And I think, as you said, we're all human, we're all changing over time. Behavior change is hard. And so you might be at different steps along a very personalized journey. So I think a couple of things that we really think about. One is, you know, we measure all of that all along the way. And I think you have to measure, you know, you can't change what you can't measure. So we're first measuring those and looking at those inflection points. And then we take a very personalized approach to where someone is on their personal journey to health. And so that's everything from, you know, setting up what your goals might be, whether that's, you know, increased activity, weight loss, better sleep, more mindful behaviors. And so, you know, kind of setting up what's primary and personal to you at that moment in time is very, because that is going to change over time. And then providing, I think, awareness and education and insights and guidance along the way as you reach certain milestones, so that over time, your experience with Fitbit or your experience with, in this part of a care team, your insights are getting better and smarter. And so your device is actually more valuable over time. I'll give you just a really concrete example of that. I've been wearing a Fitbit for a very long time. I think some order of 14 years. So I have a lot of tracked history. But my heart rate, despite, you know, many years of wearing this recently, had gone up. And I said, like, I'm doing all the right things. I'm working from home, and so I'm working out more, and I'm more deliberate, and all these right things, right? And I was able to look at my trends over time, and actually my Fitbit insight gave me an insight around, well, you did something differently over the last 2 weeks that has impacted your behavior, that has changed your heart rate. And so getting those types of insights, because I have longitudinal data over many years, actually made my experience of being on Fitbit much smarter. And essentially mine was a combination of, I wasn't working out as much or as hard because of allergy season. It's allergy season for a lot of us. We're all very tired. We're taking allergy medicines. Everything's in bloom in California. But getting that insights means that the device is getting smarter over time, that the insights are getting better. And so that helps with ongoing engagement. So really it's about measurement, personalization, and then providing right time, right place insights to change that motivation or provide something that then sparks a behavior change, even if that is different from their initial goal of where they might have started.
So Stacy, this sounds really familiar in terms of your patient journey point earlier about how we have to kind of adjust for these different patient journeys.
Yeah, exactly. I think it does. I think it all kind of it all blends together. But yeah, it's such a critical thing that we have to understand what the patient or consumer is experiencing at that point in time and in your journey to be able to get them the right care. I think if you think about this from a clinical standpoint, you know, a lot of times if you think about a diabetic patient that you know they're not controlled and they haven't been controlled for years, their A1C is, you know, 13, 14, 15, and you know they need to go on insulin. But you can't get that patient to be adherent to insulin until they buy into the fact that they are ready now to move to injectable. And so sometimes in healthcare, you know, you see some of that. And it's the same thing with a lot of the other things we're talking about. Like the patient has to be ready to, one, engage with you, to be able to take the recommendation or the treatment or whatever we're trying to do to see the outcome. If they're not ready or we're not engaging them in a way that's meaningful to them, you kind of miss the mark, right? And that's kind of been prevalent all through healthcare with different treatment options. I'm not ready to, you know, take chemotherapy. You know, I want to do a wait and see. I'm not ready to take insulin. I'm not ready to start a medication. I feel like if I can diet and exercise for the next 10 years, and I'm not going to be ready until I am. Smoking cessation, same thing. So I think, you know, it's if we learn anything, we've learned that it's a really important thing to understand what that patient is experiencing. And again, the data can help us get there, right? I think in the past, we've relied on interviews and counseling to kind of pull it out of the patient. Now we're at the point where we can leverage data to get there faster. You still have to engage with them and validate that through a conversation. One of the things I wanted to, I can go back to a question you talked about earlier about a misconception. I think one of the misconceptions we have is that patients may not be willing to have some of these deep conversations, right? And it puts up almost like a barrier to say, you know, can a pharmacy really talk to a patient about domestic violence? Or can a pharmacy really get into a conversation, or can a provider really get into a conversation about patients not able to afford food, right? And I think that is true, and we have to arm our clinicians with better ways to have those conversations and navigate those conversations. So I love the comment earlier, Fred, you made about scripting. We kind of have to go off script because these are human problems that you kind of have to evolve. But I think one of the misconceptions is that people are not willing to talk about these things. But I think they are, if you're able to identify in the journey where they are and what they're experiencing. So timing is critical. And again, the data can help us find the time to be able to kind of have that patient open up and have those conversations.
Yeah. One of the things I'd love to jump into just a little bit, and I would like to invite any of the panelists from the first panel, if you want to remain on the line with us here as we go through these questions, you're welcome to stay. If you need to drop off, of course, we understand that as well. But I want to talk a little bit about kind of engaging some of these at-risk populations and low engagement numbers, really. So what is actually effective in terms of turning around these low engagement numbers? How did you get people to keep coming back and keep using those tools to engage with different folks? Amy, I know you were going to jump in on something else, but you're welcome to jump in on that. Okay.
No, that's great. I was just going to echo Stacy's point there that I think it's those the readiness for change, right? Behavior change is hard, and they might not be ready to go. Your insulin example, to go all the way to insulin, but maybe they're ready to, kind of log their food or do something that's maybe a step on that journey. And so we like to say, if Fitbit, like little steps add up to big results. And so it's understanding their readiness for change and then setting goals that are achievable in the short term to help them towards that path to get them to where you want them. But that might be a bridge too far right away. And so that was just, I just wanted to echo Stacy's
No,
comments
that
there.
makes a
That's
lot of
really
sense.
relevant.
And Henry, I want to make sure you have a chance to jump in here. Welcome, Henry. Oh, you're on mute though, because we can't hear you. Try again. Can you guys hear Henry? No, we're not able to hear you yet, Henry. Let's try, let's give Henry a dial-in number. Yeah, now we can. Great. Go ahead.
I missed the tech check earlier with the first section.
That's okay. Go ahead.
Now, I just wanted to comment on the question you had prior about basically how do we get consumers to be excited and, and if we build it, will they come? I think definitely we are feeling bullish. So a little bit about my role. I support our patient access solution at Inovalon. So several, Will is one of our clients. And I know a lot of the conversations we've been having with our health plans that are looking to become compliant by July 1st is not only meeting the compliance rule, but how do we ensure that we're growing adoption and that the patients are actually seeing value, both from the perspective of making the data available to those patients based on all the things we've talked about here, but also for the health plan to have this mechanism to better engage with your members. I think some of the things, we don't know the answers to the question, obviously, we can't predict what's going to come, but we're anticipating that at least we think adoption is going to be initially obviously slow, like any new technology that rolls out. It starts from, let's get it out there. Let's use all of the things we've talked about in the first session, either marketing tools or awareness, meeting patients at the point of where they are, with making all of this relevant data available. We're anticipating adoption will get to where it's not going to be right away. In 2020, you're seeing all these members log in to get access to their information. But again, just like the banking industry or any other industry, we've got to start from somewhere. So what we're doing here is building the grassroots, building the pipelines to support this capability where we're now making all of this relevant data available to members. And and we anticipate that adoption is going to grow for the reasons Amy talked about, for instance, with being able to integrate this data into your personal devices. I wear an Apple iWatch, but ultimately health plans can use this access or this channel to better engage with their members. So a health plan perhaps launches a new program as part of a new enrollment. What better method is there to now leverage this channel to be able to engage with those members and have that bidirectional interoperability between the health plans and the member? So I think adoption is not going to be right where we need to be right away, but I can definitely see this growing as we continue to push more relevant data to those members. So I just wanted to comment on that thought from before.
No, that's great. Hope, did you want to jump in here? One of the things I know, Hope, is that Amwell has a ton of data on what your consumers, how they engage, what they're, how they like to engage, how they don't like to engage. One of the questions we actually got was, should engagement be prescribed by the consumer or by their behaviors, how they're interacting? So if a consumer says they don't like to, they don't want any, I don't know, contact, but they're always contacting the plan or provider. I mean, so how do you kind of wrestle with that?
That's a good question. So their behavior is in conflict with their stated preference. Yeah, that's an interesting question. It almost feels like it could sort of align with how how Stacy and Amy were thinking about, other changes that over time, maybe we change our minds,
Right.
or our foundational characteristics, whether it's the heart rate that Amy mentioned, or other more clinical points that Stacy mentioned. I don't know. Do we have the bandwidth to scale up something like checking back in with the consumer to say, gosh, we've been trying to adhere to your preference in this way. We don't want to, we don't want to outreach it in a way that's bothersome or tiresome. But it would appear as though you're interested in engaging with us. I don't know if somebody had, I'm not sure I have the answer. It's I'm answering the question with the question, but it kind of feels like maybe a touch base. What do you guys think?
Yeah, I can weigh in, and I guess right off the bat, I don't have the answer. No silver bullet, but I do think that is an advantage or that's one of the advantages of developing member/patient profiles.
Mm.
So, and again, this is just an iterative process, and we're building the data and the evidence, but you can start to, and we've worked with our clients to start thinking about, okay, well, this is a new patient of yours or member who said, leave me alone, don't want to deal with you. And yet, there are a lot of underlying conditions and issues that you as a health plan and provider have a, financial interest in. You have a clinic, like you want to make sure they're doing the right things. And one of the plans we worked with out in California, I think over time had a cohort of, members with 3 or more chronic illnesses, very, pretty sick. And who were in that bucket of pretty sick, but also wanted to have nothing to do with the healthcare system until they needed it. And so it really was a matter of helping to understand, okay, we're not going to ping them anymore. And I think, it goes back to a point that Will from Maine had made on the prior call. It's, well, they trust their provider. So let's engage with the provider, make sure the provider fully aware of the array of issues. And by the way, we as a health plan have a lot more data and a lot more insight on this member than probably their primary care physician or, endocrinologist or whoever it is they're working with. And so it's, can we work through the provider to reach out, and is that, and we'll test it, right? And maybe that patient says, leave me alone and so be it. But I think that's where you start to, you get creative and adaptable and understand that, oh, okay, they kind of fit in this segment and this has worked with other patients like them.
I can weigh in. I can weigh in on that. One of the tools that we're going to be making available to our payer clients for the patient access rule is essentially we're working with all of the major apps to profile those apps so they can authenticate into the APIs. With that, we're going to be able to essentially determine and know, the payers will be able to know which member is basically accessing their APIs and which apps they're using. So are they using a Peloton, app, or are they using a Fitbit app? Are they using a Google app or Apple app? And, with that data of essentially understanding the types of devices members are using to authenticate, one of the ways that we would be able to essentially, oh, by the way, we'll be able to tell which geographic regions, members are accessing their data from, and all sorts of insights the payers would have. It generates essentially insights to be able to now say, oh, based on some of what Fitbit might be doing in terms of how Fitbit users are essentially aggregating their information and wanting to integrate their data into the devices, it could better inform a payer, for instance, to create tailored programs based on those types of devices ultimately, or perhaps even regions that they're connecting from, right? So if it's winter time in the East Coast, but in the West Coast is always nice and warm, and you're seeing members accessing their data from those regions, it might better inform, again, just how you might want to tailor some programs to be able to suit those members as well as the apps they're using. So I think that might be one way that that data would be helpful.
One of the things I want to make sure we address is, we know there have been a lot of fears from different populations about sharing their data online with all of this whole slew of new providers and vendors. What kinds of things can you do to help reassure consumers, particularly in vulnerable populations, that their data is going to be used appropriately? Anybody want to jump on that first?
This is Amy. I'm happy to start there as the kind of consumer brand of like, this is a really important aspect of trust that we have with our consumers, right? Our trust with our users is everything. And so the way that we actually, and we've done this from the very beginning, is kind of based on some core principles. The first is just transparency. So it is, sharing. It says, it's very clear in English, not legalese, as to what data is being shared, what the purpose of that data is sharing is, with whom it can be shared and why. And so a very, kind of very transparent policy, particularly when it comes to sharing between consumer and a healthcare provider or someone else in the healthcare ecosystem, a partner of some sort. So I think transparency is the first one. I think then there's just an education and awareness that comes from an opt-in consent, right? So it's very straightforward. Here's what we're sharing. Here's why we're sharing it. Here's what the benefits to you are of sharing this data. You'll get better care. You'll have rewards and incentives. You'll qualify for some program, whatever it is, but kind of clearly demonstrating that up front. And I think that opt-in is a really important piece. And then the third goes back to kind of that member profile that I think Fred was mentioning, is that giving the user control in terms of the participant being able to opt out or revoke that privilege at any time. And kind of periodically reminding them of that, in the same way that you want to remind them, here are my communication preferences and how that might change over time. It's also, here are the apps that I'm connected with, or here's who I'm currently data sharing with, and reminding me that I always own the control as a participant as to removing those. And then I think the last one is just share the data that's relevant for the use case that's going to provide the benefit, right? So the data I'm going to share with an employer is going to be different from the data I'm going to share with a healthcare provider or someone on my care team, because I'm going to get a different benefit for providing that data sharing. And so making sure that those controls are individualized based on the use case, I think helps foster that level of trust. So those are kind of the principles that we operate under. And then we provide privacy kind of best practices, if you will, and kind of a pledge for each of those different use cases. How am I using it with a care team versus a research platform versus, another consumer app? And so I think some of those principles kind of apply across the industry.
How about Walgreens and Amwell? Stacy.
Amy, you said it. You said the two T words, and I think that underpins everything: trust and transparency. Yep. And I think that's you hit it home.
Yeah, agree. I mean, I think data protection is key to probably every organization on the panel and in the audience. So clearly, it's a priority. And yeah, I agree with Amy. I think just communicating and giving people the control with what and when and how their data can be used is really important.
Mm-hmm.
Yeah.
Go ahead, Henry.
Now, I was just I think everyone's gonna agree with you, Amy. You hit all the key points there. I guess the one thing, the key thing I keep thinking about is trust. And trust means, even as an organization, and all the organizations represented here on the call, making sure that as we're getting into this new territory with interoperability, the partners you're using, your internal controls in terms of, do you have the right SOPs? Are you high trust certified? A lot of times we all have good intentions, right? But when breaches happen, it's because there was some control that was not followed in your internal processes. Your data center was hacked into because you didn't have the right control. So I think we're getting into new territory here with interoperability. It's really the time to make sure that your internal tools you're using, your IT shop, your vendors you're partnering with, that you also extend those security, privacy concerns, and ensuring that your full system, your full infrastructure is essentially bulletproof. Because once that trust is lost and you're on the Wall Street Journal, it doesn't matter whatever marketing you did or whatever brand you did, it's going to impact that trust. So I think you got to look inside your shop as well and make sure you have the right controls in place.
I can add a little bit there really quickly, Henry. I think it's a good point, but also to add on to that, some of the data that we're starting to consume it's a very different data set than healthcare data. And so we've got the right policies in place to protect healthcare data, but do you treat the data around someone's shopping patterns and where they buy food to a certain, if they're getting healthy food, is that now healthcare data? Or we talked earlier about someone's fall risk. If we start to look at some of the data sets out there that maybe you can get data on, does the patient live in a 1-story house or 2-story house, so their fall risk is higher, like that type of data that is all really helpful and helping to us get better at risk stratifying. It's a really healthcare data. And so some people may think, well, maybe we don't have to be as strict or follow the same controls than we legally are bound to from a compliance standpoint. But I would challenge us to think that we should try to be as strict as we can for all of the data, right? Just because once we break that trust, things start to break down and we kind of lose the patients in kind of the process.
Yeah, I was just going to add that very real world example, we're working on behalf of a health plan that's working with a large oncology group in their market. And, we can talk about all the incredible use cases when you combine their clinical data with the claims data and layer in the social, all that great stuff that we love to nerd out on. And yet they had a data breach, this oncology group, and man, they put us through our paces, and rightfully so, as they should have, around, right, as Henry was articulating, do we have all the security and protection infrastructure in place? What were our processes? Could we handle this data? So, it's finding that balance, right? Because on the one hand, trust is sacrosanct. You have to protect that. And in a lot of cases, it's kind of going above and beyond what's just required, whether it's HIPAA or some of the other regulations. But it's also, at what point does that inhibit innovation, right? And keep data locked into silos and locked into institutions. So it's, and I here again, I don't have like an easy answer for that, but I do think it is, checking all those boxes, understanding that's first and foremost, but then also being able to innovate from there.
I'm just looking at, we've got this great question that came in through the registration. In hearing from everybody today about the different types of data that's being generated, not EHR data, obviously, but extraneous to that, are we putting a large burden or expectation that the consumer's provider is going to take all of this data and review it in some way? Thoughts on that? That data is just kind of growing. So now they've got the wearable data, they've got the ERX data, or maybe their retail data, or certainly the televisit is a provider, so it is provider data there. But so we have kind of this tremendous amount of data that's growing and growing. And do we expect someone to kind of look at that and look at the consumer as a whole?
I'll take a stab at that, and then I'd love my fellow panelists to weigh in. I think it probably comes down to how do we curate that data to be really consumable by whoever it is that needs it. And so as an example, member advocacy or service organizations where people are answering phones from consumers calling in, might be able to have technology where some of that information shows up. Things like gaps in care or other clinical issues can come can be, displayed in order to guide a member down a certain journey. Same thing can happen with a physician visit. One of the insights that Amwell's medical group and other physicians who use the platform can see is data that's presented to them. Now, whether, does it include all the things we're talking about today? Not yet, but there's no reason why, we shouldn't be able to find a way where it could be displayed at the moment that a provider needs it while they're engaging with the patient, and be able to make, go down certain paths in terms of their conversation with that patient. I would think pharmacists might be able to leverage the same sort of thing. But that's my thought, is it has to be somewhere where it's right on time, relevant to the conversation happening, and be usable.
It's really a care coordination issue almost. So we've got more and more data coming in, and who's going to be coordinating all of that data and care?
Yeah, I like to think about the problem list management, right? So, this idea of having this interoperable problem list, or this interoperable, like it's one patient care plan that many people are interacting with. So if I'm able to see as a clinician that the physician addressed this particular problem or made this action plan for it, then maybe I don't need to address it today, but I may address something else lower on the list, or vice versa, right? So the better we get with, being interoperable and kind of go into that kind of pathway where there's one care plan, many different stakeholders, but we're all managing sort of the one patient, I think that will help, because we're not we get more data, what we don't get is more time. And so, to Hope's point, how do you, for the moment you have with the patient, like which one of these things do you want to, which is best for you to address based on kind of what you're serving the patient with and what the patient is ready to work on. All of those things, it almost has to be like this dynamic problem list that somehow intuitively the system knows, or technology knows, like, this is the one we want to talk about today because it's the right conditions to address this particular problem. That's
it's
a far-fetched vision, but that's hopefully where we can grow to.
It's the aspiration.
Hang on.
Yeah.
Oh yeah.
No. Either one of us, I think I was just going to add on to Stacy's comment that I think it's data with purpose and in context, right? And I think that's what both Hope and Stacy were speaking to, is just it's not just data for data's sake to say we have the most. It's data that is going to be useful, either in exception management, or, in my case, I'll be the first person, I should say it, since I'm the Fitbit person, right? Is no one cares if I walk 10,000 steps a day. Maybe yesterday, my physician probably doesn't care about that. But if my trend is that I've, walked half of the steps I normally do, or if I have CHF and my weight has fluctuated by 5 pounds, that's very pertinent to my care plan at that time. And so it's really about sorting through the noise of the data and giving that data context, because to Stacy's point, there's not more time in the day and you're sorting through more data. It's how do you surface the right data at the right time to help with that care plan. So I think it's about that context and context setting that is really going to make the data valuable.
Yeah, and I would just add that, we could spend days, if not weeks, talking about Kaiser and some of these closed systems, but that's one of the advantages they do have, right? They have this integrated data set. They have tons of experience. I think, are they, Stacy, in that kind of like that dream vision of, perfectly well coordinated, well timed? No, and I can say that having worked with them and having been a member. But I think they're light years ahead, and so it's how do we, in a system that is going to be way more fragmented once you get out of the kind of the Kaisers of the world, to curate that and manage that and make sure that it's all choreographed. And I guess I see it, and I'm old enough to know or remember a time when I first got into healthcare when it was the opposite problem of, like, we didn't have a lot of data. Nobody was trying to engage these at-risk patients. It was sort of like, hey, too bad, these diagnoses, like, good luck.
Yeah.
We'll help you when you're in our, clinic or our hospital, but other than that, go for it. And now, in some cases, in some markets, like, it's the health plan. That health plan is outsourced care management. It's the physician. Like we're tripping over each other, and that creates its own set of problems, no doubt about it. But I guess in the grand scheme of things, I'd rather that and get to a point where can we coordinate that and choreograph that more effectively, as opposed to just, ignoring them and, not having any data being funneled to the right sources.
Yeah, I
That's
agree.
where interoperability comes in, right? That's where interoperability comes in.
Yeah.
That's right. I was just thinking about, as you were talking, I was thinking about the payer-to-payer data exchange coming as well, because, there's all this push now to get data to the consumers, but ultimately what happens after all that data gets into all these devices, right? How do you now promote interoperability so that that data can truly be shared across health plans, of course, care coordination groups? And the good news is that we're still innovating, right? So we're on this train. We've boarded on the station behind, and we're innovating as we go. And I think with the data normalization, with standardizing on the data formats so that it can be interoperable across devices. I mean, isn't it beautiful that you can have a patient access API that can be any app of the members choosing, they can connect to it and get that data. I definitely think the peer-to-peer data exchange as well will continue to promote that usability of the data. And I agree with all the points made from the panel as well.
So how do we close that loop? We've gotten a couple of questions about, and Stacey, I think your example and hopes are really relevant here. So say you do have a consumer that has that conversation, the pharmacist has the conversation with the consumer while they're at the store or on the phone. Hope you're in the middle of a televisit and the consumer communicates something that's really relevant. How do we get that information back to the care team or whoever the primary is?
Yeah, that's something we are trying to explore now from a pilot perspective is, and I kind of said this earlier, if we feel like if our way we can help this problem is through the engagement, through data, doing some validation of the data, what happens next? And so we think about these in three stages. One is the patient identification and risk stratification. Two is the engagement with the other stakeholders. So do we need to pass that to the provider? Do we need to pass it to the health plan? All the different folks that this information will be relevant to, how do we get it to them in a digital manner or a usable manner? And then the last piece that's the big piece here is how do we get the patients into the programs? And so in the pilot that we have with Highmark, again, like there's just programs that the health plan may have. There are community-based organizations that are out there. There's tons of nonprofits out there from food banks and different transportation options, housing programs, right? So how do we get the patients into those programs? And so, that's where the technology and the innovation can come in and create some of these platforms. And some of these organizations are starting to make some progress here to be able to link in programs to a central place and have patients either drive, they're kind of going out and putting in their zip code and finding options, or the health plan steering you, or different places steering you. But those are the three buckets that we think about: identification and risk, engaging with the different stakeholders, or notifying stakeholders, or sharing this information, sharing the insights to get us to, okay, what's out there, what's available, how can we get the patients, how can you help kind of get the patients into the programs?
Hope, could you comment on that? Oh, except you're on mute.
Again. Well, the one thing that's coming to mind to share is something that folks may have heard that we announced, which is our Converge platform, which is sort of the next iteration of our platform at Amwell, which is intended to really sort of open up the ecosystem and allow different entities or different functions to be sort of plugged into the platform, and to create sort of this streamlined one-stop place for providers to go, or for health plans to sort of plug in their own clinical programs, whether it's a pilot that's specific to a high mark population or it's something else, to try and pull the string through all of these different separate, well-intended touch points with the patient and put them into one place. So, you know, I think as we innovate through technology, any of us innovate through technology, finding a way to streamline and simplify where folks can go for engagements or care direction or choreographed experience. I think that's something that we'll probably be hearing a lot more about. And then I thought your question was also about how do we get some of that data that we have in our exchange with a patient or interaction back to perhaps primary physician. So, you know, plugging into things like EMRs and making sure there's a record of that interaction that goes to a place where a primary physician would see it would be key. And certainly, you know, where we have health plan physicians plugged into our platform, that's already in there, or health systems physicians who are seeing their own patients on the platform. It's leveraging, they're leveraging EHRs, but more use of that, I think, will drive that gap to be more closed.
So Caroline in our audience has a great question. So I'm concerned that physicians are already super burned out and the answer keeps coming back to getting all this data back to physicians who have limited time. Thoughts about this as a potential bottleneck? Anyone want to tackle that?
Yeah, I mean, I think it goes back to the thought that, you know, there's a care team, right? And so for a long time, the physician's kind of been a one-person show, or the expectation or the burden has been on the physician. I think that, you know, a lot of different professions, nursing and pharmacy and care managers and social workers, I think we have to kind of find a way, and there's been great progress. I mean, for the Kaiser comment, I think this is something they do really well, you know, is really expanding that care team and making sure there's a shared responsibility, right? So that it's not my problem to solve because it's my patient. There is a network of stakeholders here that would like to help and can help. And maybe there's a physician oversight, or maybe there's a new role in the care coordination world where there's somebody to play that oversight. But you're right, we can't put it all on the physicians. Again, we got more data, we don't have more time. And so we talked about surfacing the right information, but also I think it's making sure we get better and clearer on who can help where. And it doesn't always have to be very defined. And I know there's boards and scope of practice and licensing requirements that we have to follow. And so that's there, but you know, if we can be more fluid as well, right? Sometimes if it's patient education, you know, a pharmacist can do it, a nurse can do it, you know, a social worker can do it, different people can do education. And so we have to be somewhat flexible to allow for some of this coordination to happen in a more seamless way. But I think we have to really leverage the entire team.
Mm-hmm. One thing I want to make sure we have time to address are some of the interoperability issues in terms of engaging consumers. So we know that everybody's on different platforms. So how do you, as kind of large providers of data and collecting data and interacting with consumers, how do you handle that issue? And what are some of the biggest challenges that you have? Amy, why don't we jump to you to start with?
Sure. It's a messy one, which is, I think, why this is the first one that no one jumped in first. You know, I would say, you know, for us, we really think about, you know, the participant or the user, you know, controls their data and where they want to share it and how they want to share it. I think it has been a long journey to figure out how to best integrate that. And it's a journey we're still on to figure out how to best integrate that into the healthcare system. I think, as many of us can probably relate to, much of that has been a one-by-one. So, you know, go to this provider or this plan or this care team, to Stacy's point, and kind of knock those down one at a time. I think the hope is, you know, that we can do that in a more standardized approach in the future. It's something that's really important, and we really do. The approach that we really take is, what are our participants asking for, and where is their receptivity by the provider or the plan or whoever the entity is that we'd be working with, and really try to help navigate that. We foster an open API, ecosystem to allow for that, but just putting it out there doesn't mean that everyone will come. It requires partnership and integration, and it's almost now whose API is going to integrate with whose and who does the work, right? That's a lot of where it is. It's honestly, it comes down to resources and timing, and who can make that happen more quickly. And so I think a lot of that is just a very deliberate and focused, like my team, that's what they do, is all they do is think about how do we better partner and integrate into the healthcare ecosystem. Yeah. But we're doing that on kind of a one-on-one or a one-to-one approach now with each system. So I think there's room for improvement there as we come up with better ways of standardization. But I think that's still a long journey as we figure out, because there's just, I think it goes back to, and I'd be interested in other panelists' thoughts of, like, there's just work to be done regardless. Like, just saying it's there, somebody still has to do the work to integrate them. And I think that's really where the brass tacks is like, who's going to do that work? How long will it take? What's the incentive to do that work, the participant or by the provider? And I think that's really the challenge that most of us face.
That's a great question, actually. What is the incentive to do that work?
If I can,
one response, and just very quickly, and maybe because I'm here in DC, but I do think, and I probably hear boos and hisses virtually, but there is a role for regulation. I really do think there is a role for the federal government, maybe, and take all the shots you want at the rules and regs that they've issued, but to say, we're going to do this. Consumers, this is not your data, health plan. This is not your data, physicians. It's the patient's data. They should have access to it. It should follow them wherever they go, period. End of story. And we're going to make that work, and we're going to stumble our way through, and it's not going to solve everything. And you're absolutely right, Amy, because even with all the regs and kind of like level setting and kind of baseline expectations, there's still a lot of heavy lifting that has to get done. That isn't, you can't have bureaucrats coming in saying, do this, don't do that. But I do think, as compared to 5 years ago, 2 or 3 years ago, we're in a very different place. And people will grumble and, can't believe we have to do this. And what do you expect us to do by when? But, like, guess what? Too bad. Do it. And it's a starting point. So I think it's, as I said, leveling the playing field, kind of getting us all to a bare minimum around interoperability. And then I would just add with Hope's point earlier, creating, I think there's a real appetite and business opportunity for the organizations that aren't coming in with, well, I've got this point solution and this capability for this little population, subpopulation, or for this little care setting, but aggregating it, bringing it together. Because I know with our health plan and health system executives, they're just done with like this little doodad to do this and this, like they want, like, bring it all together. So I'm not spending time wasting money trying to integrate all this. So, I think it's a combination of regulation, and as well as there are business opportunities around interoperability that there weren't before.
Stacey, we're going to jump in.
Yeah, no, I agree. There is a place for policy to play here. And I think about where we are now with the interoperability rule. It was needed, right? Because, it's not all, I don't think there were bad intentions, right? But when people start to innovate maybe earlier than some, it became proprietary. It became a differentiator, and that's normal, and that's normal business. But it's not, I don't think it's all bad. It also was, some folks just had the vision or saw a problem and didn't want to wait for this perfect world solution or this standard to be created you can just go follow, right? And so you have to start somewhere, which is good, and that's innovation. But what that then causes now is 10 years later, we've got a lot of disparate systems. So I think it was the right time, for the government to kind of step in and kind of really put the focus on interoperability. So we may have to go 2 steps backwards, but then I think it's going to help us move forward. So I agree. I think there is a need for it, and the standards kind of just follow, right? Same thing with the standards. Like we have to have a standard way of doing things. Otherwise, again, we're not trying to stifle innovation, but it's needed so that we don't get too far down the proprietary pathway that we can't pull back. And I think that's happening right now with, you see a lot of portals, you see a lot of health plan portals, you see a lot of different portals that patient portals. But then that it's one patient, right? And now they've got 20 places to go to access different information. And so we just have to balance that. But I do agree, if the regulation was needed, and it is scary, and it's almost like, oh no, I have to do it. Where am I going to find the time, the money to do it? But it's gonna help us in the long run.
Yeah, if I can add, I mean, I think I agree with all the points. I also agree regulation and standards have certainly helped. One of the things I was just thinking about from a provider standpoint, Jen, one of the questions you asked earlier, I worked on the provider side for several years, and initially when meaningful use was first launched, it was such an exciting thing. I worked for the one health system that implementing it, and getting all this HIE data, ADT data was exciting. And then it became to a point where it's like, oh my gosh, too much data is just as worse as not having any data at all. Like, what would I do with all this? So from a provider standpoint, it's really around how do you send meaningful data that is within the workflow in context so they can take action when they're doing what they already do anyway. Several EHR vendors are starting to support those capabilities with Smart on Fire and all the different API tools. But on the consumer side as well, there is some concern because there's all this data that is about to be pushed to consumers. And I think, Stacey, you made the point, or maybe Amy did earlier, really what's going to drive adoption is making sure that data is in context and it's meaningful. Because if we view all of this as just check the box, we just want to send the data because the Fed said so, it's a compliance rule, there are penalties, and don't approach it from this simplified, let's just give the patients the data they need and have it be in context so they can take meaningful action. I think the apps that are going to end up being in this game a couple years from now are going to be those apps that tailor the UI and make it meaningful and integrated with other apps or other tools that these consumers are already using. So that's going to be the key. So making the data meaningful to the ultimate end user of it is really what's going to be key here.
One good example to that is what we've seen with medication reconciliation. It's a classic example where medication reconciliation required a lot of data, a lot of interoperable data to share a med list, which, much like our SDOH factors, change over time. I think we've all kind of, as patients, been asked this question, like, are you still taking this medication? And you're like, I haven't taken that in 10 years, but it does not go away. But then there were some regulations and almost like the check marks to say, yep, you did a medication reconciliation, but did it really get to the best possible medication list? And did that best possible medication list get to the next provider? We're still dealing with that. And so we can learn from some of the examples with SDOH so that hopefully we don't go down some of the same path. We have to learn from what we've seen in the past. Same thing with the PDMPs, right? It was, again, great use case to create the state databases with the medication information. But how do you get that into the provider workflow now? How do you make that interoperable and usable in a meaningful way? So there's a lot of good examples that I think we can draw from with SDOH and hopefully make some progress faster because we have now, we're not starting from zero with this.
I'd love to do we're almost out of time, but I'd love to do kind of a quick round robin here. So quick words of advice to folks who are listening here, and they're all trying to figure out how to target consumers. So if you could give folks kind of one piece of advice, maybe either a lesson learned or, thoughts about, key data to target consumers, what would you tell people? Let's just do kind of a quick round robin here. So some quick advice to our audience members here in terms of targeting consumers. Henry, I'm going to start with you.
Yeah, so I think we've touched on some of the themes. I think, it's really important as part of all of this interoperability rules and mandates to also make sure we're taking care of patient education and member education to go along with it. We're all in our bubble. At least I am. I feel like I'm in the bubble of trying to support our clients become compliant. But some of the questions I bring up in my weekly calls with my payer clients is, what's your marketing strategy? What's your education strategy? How can we work to start to build education into your websites and do some sort of outreach so that members know, first of all, that this is coming, and also start to paint the vision of how they can start to consume this data and make meaningful sense of it. So I think it's just, it may not be sexy, but just a simple member education awareness, and not losing sight of that piece that we can really have our members consume this data and make good use of it, but not doing any kind of outreach or maybe even surveys to say, how would you want to see this data? So I think getting that member perspective and having it inform the programs we're developing is something that I would say that we should be considering.
Great. Hope, how about your words of wisdom, Hope? What would you advise folks who are trying to target consumers effectively?
Yeah, I think we're probably going to be summarizing some of the themes that we all talked about. So I think I'm going to anchor on the trust theme that we talked a lot about. I think until we tackle, as organizations, building trusting relationships with our consumers, we're probably not going to have great receptivity. And a part of that trust is built by communicating meaningful messages at a time when somebody needs them so that they feel relevant. So that would be my advice.
That's great. Stacy.
Yeah, I would say building on the trust, I would say you have to ask patients, right? So strike the balance between getting the data and also asking patients what their preference is, or asking patients to validate the data that you bring in to make an informed decision. So I would just say, like, don't lose sight of the patient with the more data we get. I think there's a way to blend it, and then it becomes more effective, more meaningful.
That makes a lot of sense. Amy.
Sure. So I would say that, and we've talked a lot about this today, but treating participants or patients or members, however we think of them, as consumers, which means that they do have individual choice. They want to, they may be willing to engage in different strategies, and they may have different preferences on how and when and where they engage. And so designing flexible systems that allow for them to have flexibility and meeting them where they are, and allowing them to have some of that control in terms of the ways in which they want to engage, and then making it very easy, fun, and I'll use the word fun, easy, engaging, and fun for them to participate. It's like, how do you reduce the barriers? Right now, it's so hard. All these different systems, all these different passwords and logins, and who can connect to whom. And the easier that we can make that, and to Fred's point, we've made a lot of progress there. But if we can make it easy, engaging, and fun for them to be able to participate, where they see that value and that benefit to them of why they're going through that, then we do that in a way that is personalized for them on where they are in their journey to health. I think that can really have an impact on outcomes.
And that leaves Fred.
Yeah, I wholly agree with all the points that were just made. I guess in the spirit of, before you even really start engaging with members, kind of picking back up on something we talked about, I can't remember if it was this session or the one prior, but really doing the member journey, the patient journey mapping. And the only thing I would add there is not only understanding how the patient or member winds their way through the system, or for a particular episode of care or experience, but it's who are all the individuals, whether in your plan or outside of it, who are contacting and touching that patient. right? And then really, again, before you start rolling out this or that great intervention, it's just figuring out who's engaging with them, how do we align those messages, who's going to be most effective at conveying that message, again, layering in the patient profiles and preferences. It's a lot of work, but you just think about it from your own standpoint of, do you really want to be pinged by the plan and your physician and, a tech company? Like, it's just overwhelming. So coordinating that, I think, is a big undertaking, but I think it's going to have lasting impact in terms of being able to engage with your members and patients.
Great. Well, I want to thank everybody for their thoughts and insights today. I think we've had a great discussion for the last 2 hours. Appreciate everybody's time. Thank you for hanging in with us here. If you've been with us the full 2 hours, appreciate Inovalon support today. And I hope everybody has a wonderful afternoon and be engaged. All right, everyone, have a great day. Happy Memorial Day.